Welcome, I'm Paige Stover, here today with Dr. Kathryn Seifert. Dr. Seifert is the author of 2 assessment tools that are used by the healthcare profession in an effort to predict future violence in children and adults. Dr. Seifert, your perhaps best known assessment tool is called the CARE 2. How does this work, and how is it used, and how does it help me as a healthcare professional diagnose the behavior that's going on with my patient or my whoever I'm working with?
The CARE 2 is an instrument that not only measures the probability that a youth might get in trouble with a violent behavior in the future, high, medium, or low risk, but I think the more important part of what the CARE 2 does is it identifies the evidence-based practice that it is important to put into place to prevent a violent act from happening, or really to reduce the risk that a child is going to become violent. So we have to be very careful about identifying children as at risk for violence. However, if we're going to reduce the risk, that's another way of looking at it. And so we're looking at intervention.
Now, if I were a school teacher or I worked in the criminal justice system, can you sort of describe the context in which I would decide to use the CARE 2 tool?
Absolutely. I can give you a couple of recent examples that people have brought to me. So an 8-year-old came to school and started telling his friends that he had a knife and he was going to stab somebody. And so the information got to the principal, and the principal brought him in. And so this would be a situation where absolutely this child should be administered a risk reduction instrument of some kind, a CARE 2, so that they know, number one, is this just a kid who's running off at the mouth and has no intention of doing anything harmful? Or is this a kid who has a huge problem and somebody needs to intervene appropriately, or you're going to have a real problem on your hands and somebody's going to get hurt?
So how is the assessment administered? Does the adult ask the child questions, or describe to me what the interaction is to sort of get the information you need from the child?
The CARE 2 is filled out by a person who has already interviewed the child and the family, because what you want is you want information from different points of view. You're going to interview the teacher, you're going to interview the principal, you might interview a friend of his. You want to get as much information as you can, and if the family, as it very often is involved with public agencies, you're going to want to get releases signed and you're going to get information from the public agencies. When you have all of that information, then you sit and fill out the form. It is not filled out as you interview, because you're going to interview lots of people.
I would imagine in a lot of these situations, the family wouldn't be cooperative.
And that is true. Very often they are not. But I have also seen situations, in my practice in particular, where a school will send a family and a young person to us and say, you may not return to school until Dr. Seifert says that your risk has been reduced to a level where you are safe to be in school. And then they have no choice.
Well, I don't know. Maybe it would seem to me some of these kids are fine not being in school. That's almost like they don't want to be there anyway.
Absolutely, they don't. But the longer they're not in school, the more you're going to raise their risk factors, because structure, being involved in a positive activity, being influenced by positive adults, those are all resiliency factors. Those are things that are going to reduce the risk. If you turn them out into the community to do whatever they want, they're going to be recruited by a gang, or they're just going to get into mischief. Children need to have adults who set some level of structure for their day so they don't get in trouble.
Now, if I'm a school teacher or a social worker, how do I get the CARE tool to use? Do I have to have someone's approval to use it?
No, it's available to any professional that works with children. It's on my website. There's a paper version and there's an online version.
What is your website?
And the website is drkathyseifert.com for the paper version and care2systems.com for the online version.
And then you are recently debuting a very new, I don't know if you call it an assessment tool or a risk reduction tool that is similarly used, but in this case with adults.
Correct. And the new one is called the AVERT. And so we're trying to avert terrible things from happening. It is for males only, and it is for this eruptor group, ages 15 and above, well, 15 to 40. And it is for this group of young men that are psychotic, delusional, socially awkward, and will do something, are highly likely to do something awful if they hit a flashpoint. And so what you do is you examine the risk factors, and along with that will be the evidence-based practice of what you need to do to reduce the risk of exploding when they hit their flashpoint.
And then you have the F-risk model.
And the F-risk model is based on the same thing. You need to use one of the other two instruments so you know what the risk factors are. And so basically someone who's at high risk has a high amount of stressors and a low amount of coping strategies. And what you want to do is you want to increase the coping, reduce the stress, and you want to reverse that model for the young person. The other piece of that is it's not just enough to reduce the risk factors for that young person. We are more than just an individual. We have families, we're in schools, we're in communities. We have to have meaningful life activity. And so it's about looking at the whole person and how he exists in his home and his family, his school, his workplace, and all of those become factors where there can be risk or resiliency. And you're always looking for ways to increase the resiliency through support, through treatment, and reduce the risk by helping people be able to deal with their stressors.
And if I understand correctly, part of the uniqueness of your new approach is that it is in fact a risk reduction model as opposed to a pure assessment tool. Is that accurate?
That is correct, because even though our risk assessment tools are very good, they're not yet to the point where they're 100%. And I'm not saying don't use them, but what I am saying, the important thing as far as I'm concerned is what do you do with it after you know you have somebody at moderate to high risk for being violent? What do you do about it? Well, you have to have a model for reducing their risk. And that's really where I think the whole field now will go, is in terms of reducing risk.
So then how do you segue, if I'm the professional, how do I segue to the information I get from the tools you've just described to some sort of prevention in the real world?
You will, if you use these instruments for risk reduction, once you complete it, you will have an intervention plan that is individualized for the particular person that you are working with. And so if you follow that plan, you will reduce the likelihood that that person is going to commit a violent act in the future.
What else needs to happen, Dr. Seifert, at a policy level, in the community mental health system, in the criminal justice system? In your opinion, what else needs to happen in the United States for us to reduce the risk of violence in both children and adults?
In my opinion, every agency that deals with people who potentially can be violent needs to have some kind of risk reduction tool so that when they interview, assess, look at a young person or an adult, they immediately know what's the next step? What do I need to do to reduce this person's risk in the future? And so, for instance, if you're in a school and you have a bully, suspension and expulsion is not sufficient to solve that young person's problem. You're actually raising their risk by expelling them and them not having adult supervision. And so what do you need to do to reduce the risk? You need to send them to somebody who can give you a report that says you need to do 1, 2, 3, 4. And that is not always a regular mental health provider. It's someone who understands what are the risk factors for violence and what do I need to treat.
Are there things that need to happen legislatively, funding-wise, administratively, that could support these efforts?
I think that all of the above. We need to have something legislatively that gives us permission to do it. We need something funding-wise that identifies somebody in a school or a workplace to be able to do that. And you need to have some way to train and distribute tools to be able to do that to all of, I mean, we're talking about a large population to distribute that kind of information. And this is new material. This is not something people are yet thinking about. However, I would go back and say that it is recommended that every workplace, school, and college in the country have an interdisciplinary threat assessment team active within their organization. And I know that's happening in some colleges. It's not widespread yet, but every threat assessment team should have a method of determining what evidence-based practice needs to be put into place to reduce the risk of those individuals that they evaluate through the the threat assessment team.
I know in the community where your private practice is based, in the Eastern Shore of Maryland, you've had a great deal of success with what you're calling school-based mental health.
Correct.
Can you describe that system and how you rolled it out?
I can, and this is one of my babies, if you will. So we initially had a grant to get this started, but my idea was, if you're going to help children where they are, where are children? Children are in school. And so we had a little grant. We went to the principals and said, I'm going to bring a therapist into every school in your county, and it's not going to cost you anything. And I will see, not me, but I will have someone see every child that you or one of your teachers or your counselor has any concern about. And then we will provide services to any child that needs them within your school, and it's going to cost you nothing. I mean, what a proposition. Who could turn it down? But
then how do these services get funded?
Well, initially through a grant, but once the grant was up, then I have a regular mental health clinic, and so we bill insurance, we bill Medicaid, just the same as we would if we were in the clinic, and so it sustains itself, and we have a little bit of grant money for children that don't have insurance, and so we're able to see every child in a school that appears to have any kind of problem, and the initial is determine, is this a little bit of problem that we can solve very quickly and very easily, or is this a big gigantic problem and we need to get the parents in, the teacher in, and solve it together.
Do you have enough data yet to know if you are in fact creating an improvement?
Absolutely, we do. We've written a journal article about it, and what we've shown is that we, on every indicator that we measure, we reduced violence in every school that we were in. We reduced suspensions and expulsions in every school. We decreased mental health symptoms for all the children that were in our program. Parents reported that their children were doing better at home. Self-esteem was up. Children's commitment to school was up. We measured a lot of measures, and in every one, the children did better, the schools did better, violence was down in those schools.